and welcome to this last session of the April 2021 meeting of the American Philosophical Society. These virtual meetings have the unfortunate effect of eliminating the chance for us to engage in informal conversation, which has, of course, long been a highly valued part of the proceedings. And as you know, the November 2021 APS meeting is also more likely than not to be a virtual event. As a modest improvement on this and the past meeting, we're thinking of opening the business meeting about 30 minutes early and closing it about 30 minutes late in order to give us a chance to visit informally. If you have some thoughts about that, please let me or Annie Westcott know. Please note that you may access closed captioning by clicking the CC link at the bottom of your screen. There will be a question and answer session following each talk, and you may enter a question at any time using the Q&A function at the bottom of the screen. While my introductions of our speakers will be brief, more complete biographies are available on the meeting page of the APS website, and there is a link to the meeting page on the front page of the website, www.amphilsoc.org. Our first presentation this afternoon will be by Ann Case on Deaths of Despair and the Future of Capitalism. Ann Case is the Alexander Stewart 1886 Professor of Economics and Public Affairs Emeritus at Princeton University, where she continues to teach in the School of Public and International Affairs. Dr. Case is best known for her wide-ranging work on health, family structure, and demography. She's done prize-winning work on the origin of the gradient, which shows that the effect of family income on child health steepens as the child grows older. She discovered that the inferior morbidity and superior mortality of women comes from the composition of disease. Roughly speaking, women get conditions that make them sick, and men get conditions that make them dead. She's also one of the leading scholars of the effects of the AIDS epidemic on child and family outcomes in South Africa. Her latest book with Angus Deaton, Deaths of Despair and the Future of Capitalism, was a New York Times and Wall Street Journal bestseller and was shortlisted for the Financial Times and McKinsey Business Book of the Year. Her paper on the deaths of despair among midlife whites in the U.S. won the Proceedings of the National Academy of Sciences Cocciarelli Prize and attracted enormous attention. Ann Case was elected to the American Philosophical Society in 2017. Ann, the floor is yours.
Thank you so much, Bob. It's such a pleasure to be with you this afternoon. I am going to share my screen. If I can, there we are. I want to give you 20 minutes on the research that Angus Deaton and I have been doing and continue to do on what's happening to life for people with less education. This work has grown out of a series of papers that some of which culminated in a book that we published last year with Princeton University Press, where we argued that even before the arrival of COVID-19, the lives of Americans without a bachelor's degree were coming apart. Now that's 2/3 of people in the US aged 25 to 64. In the book, we document what that means in terms of despair and mortality, and we talk about the long run forces that we think are behind this. Now, we spoke about this at the APS very early on in our research for the book. And so just to give you a link between what we talked about when last we talked to you about these issues and where we've gone since then, I just want to show you one slide with mortality from drug overdose, suicide, and alcoholic liver disease. Now, as a shorthand, we refer to these as deaths of despair. And literally it was a shorthand so that we didn't have to keep saying those three causes of death. But the press picked up on that pretty rapidly, and it's sort of entered regular parlance now. And what you can see, if you look at these, this is for one particular age group, but it's true for every 5-year age group in adulthood, is that for each of these causes of death, mortality rates for people with less than a bachelor's degree have just grown and grown and grown since 1990. People with a bachelor's degree, there's been a small increase, but it's been dwarfed by people without a BA. Now, since 1989, the US Standard Death Certificate has recorded education. And so it's possible for us to take our work back that far, but not any farther. The work in the book, and most of what I'll show you today, is based on 73 million death records, which you could pull down from the National Vital Statistics yourselves if you'd like to. We think of these as all being sort of a piece because it's all death by one's own hand. And it's the case that the increases in these three causes of death were large enough in midlife to cause life expectancy for the US as a whole to fall for 3 years in a row in the 20-teens. And that hadn't happened in a century. So it's actually a large change that we documented happening to this group. We think that education is like a knife that you can use to cut not only mortality, but also how well people are living, how much pain they're in, and also what their living arrangements look like. And it's increasingly the key to a good job and ultimately to a good life in our ever more meritocratic and unequal society. The political philosopher Michael Sandel, in his great new book, says the college degree is a condition for dignified work and of social esteem. Now, what does that mean when you get it home? Well, what that means is if you look at wages for people without a bachelor's degree, on the left-hand panel here, we're looking at median wages. That's the 50% mark, adjusted for inflation, for men aged 25 to 54 without a bachelor's degree. And you can see there is this long run, a downward trend in their wages. And simultaneously, there's been a long run downward trend in their attachment to the labor force. So these little red lines mark recessions, and you can see that employment relative to population falls in a recession, then people climb back into the labor market, another recession hits, it falls again, but it never reaches a peak like a previous peak. So there's been this ratcheting downward in people's attachment to the labor market. For women, the picture is similar with a lag, so that for women, the high watermark for employment to population ratio was 2000. Excuse me, but you see something very similar for women as well. Now, there's little wage change within a job. So loss of wages and work comes from losing jobs and replacing jobs. And the replaced work is often much worse work. It's oftentimes outsourced. It's to an outsourcing company for transport or security or food services or cleaning. There's no ladder up, there's no possibility of advancement, there's no on-the-job training. So there's no sort of promise that hard work is going to lead to higher wages or a better future. We see this, and we argue in the book that this is really less about the loss of material well-being, although that's not trivial, but it's much more a loss in meaning and status that comes through work. For people without a BA, it's become the case that people think that they cannot get married until one of them has a good job, a job with prospects. So over this period of time, marriage rates declined dramatically. Now, cohabitation is up, but those cohabitations are quite fragile. So there'll be a series of these cohabitations, multiples of which might have children born into them. But that means there's instability in work life, there's instability in home life. There's also been a real loss of community. And that, we argue, is a Durkheimian recipe for suicide. There are many parallels here between what happened to the white working class, which is what we primarily focus on in the book, and what happened to the Black working class in the 1960s and 70s. And we can talk about that during Q&A if you'd like. We go into quite much more detail in the book. What happened to the working class? Well, labor was weakened by globalization, jobs were moved offshore, and by automation, so jobs were replaced by robots. But that happened in other rich countries, and we haven't seen deaths of despair rise in other rich countries. So it led us to think hard about what's different about the US. So certainly one thing that's different about the US are opioids. That we argue in the book that despair preceded the opioid epidemic, that drug and alcohol and suicide mortality rates were rising prior to the arrival of OxyContin on the market in 1996, where any physician with a script pad can write you a prescription for heroin in pill form with an FDA label on it. So things were going south before then, but certainly the opioid crisis made this much more horrific than it needed to be. The opioids landed on ground that was fertile for abuse. And big pharma targeted areas where they thought the demand would be high because people were less skilled, because people had less education. So there's a lot to be answered for there. But that's received a lot of attention in the press, and so I'm just going to leave it at that for now. But what else is different about the US? The American healthcare industry. We have the most expensive healthcare in the world, but on many metrics, Americans have the worst health in the rich world. I was raised to believe that we were the healthiest people in the world and we had the best healthcare in the world. But it turns out life expectancy in the US is below any other wealthy country. We're down in the middle income country range. In the book, we argue that life expectancy in the US fell not in spite of what we spend on healthcare, but because of what we spend on healthcare. And I want to just give you a comparison with other rich countries. And make an argument for how this connects up with what happened in the low-skilled labor market. If you look at life expectancy at birth and you graph that against health expenditure per capita from 1970 to 2015, this is what it looked like in the UK, life expectancy going up, spending on healthcare going up as well. If you compare the Brits with the Aussies, you see they're in the same neighborhood. Canadians spend more, but they're still neighbors of the UK and Australia. France is in the same neighborhood. Now the Swiss, which are the next most expensive healthcare system after the US, the Swiss spend a good deal more than we see spent in these other countries. We use the Swiss as kind of a benchmark, though, a conservative benchmark, to say, if we could only spend what the Swiss spend, how much would we save? And what does the US look like relative to this group? Well, between 1970 and 1982, life expectancy was lower, spending was a good deal higher. By 1990, we're not keeping pace in terms of life expectancy, but we're certainly spending a great deal more. And by 2015, the US has left the herd altogether. Now, the US spends 18% of GDP on the healthcare industry. That's $1.05 goes to the healthcare industry. The Swiss spend a little more than 12%. So if we could spend as a percentage of GDP what the Swiss spend, we would save more than $1 trillion a year. That's more than $8,300 a household. And that's just the excess spending, right? And that's only to take us to the next most expensive country. There was an article in JAMA recently which did this calculation from the ground up and found something very similar. So we think that this excess spending is wreaking havoc with the low-skilled labor market, because that spending on healthcare has to come from somewhere, has to come from wages or profits or taxes. People may think that their employer provided healthcare insurance as a gift, but that gift is being deducted in part or in whole from what would be a paycheck. So if I'm an employer and you're worth this much money to me, a given amount of money to me, I don't really care whether I give it to you in wages or if I hive off part of that for your healthcare premium and give you the rest in wages. So as the healthcare premiums went up and up and up, there was pressure on wages to go down and down and down. And many companies who face their share of a $21,000 a year healthcare premium for a family policy, they just decide it's not worth it to hire those low-skilled workers. They decide to outsource those jobs. So the premia don't vary much with worker earnings. It's like a fixed per worker tax. So it has a lot in common with the debate we have on a perennial basis on raising the minimum wage and will that cost us jobs? There's a lot of discussion about that, but there's very little discussion on what these healthcare premia mean to the low-wage labor market. And we think financing healthcare in this way takes a wrecking ball to the low-skilled labor market in the US. It's also the case that US states have to pay their share of Medicaid to provide medical care for the poor, but that leaves less every year for schools, for the once great state university systems, for infrastructure, for other things that we need. And so we think that the fact that the healthcare system that we have is so expensive and it's run in the way that it is, just continues to have cascading effects on all parts of the economy. Now, what to do about any of this? In the book, we argue that we are in favor of capitalism, but we think it needs to be fixed. It needs to be put back up on the rails, not abandoned, but made fairer. And we see healthcare reform as an injury that the US is inflicting on itself. And that would be then something we could think about doing, which could help to shore up the low-skilled labor market. We think possibly COVID might give us a chance to do that, but there are 5 healthcare lobbyists for every member of Congress. They're there on top of the legislators when they're writing bills. And so they are protecting this industry very well. It's a very powerful industry at this point. In the book, we use that as an example, but there's been more generally a rise in corporate lobbying and a decline in unions, and it's left low-educated workers with very little representation in Congress and in Washington more generally. And as the old adage goes, if you're not at the table, you're on the menu. Now, I wanted to leave just a couple of minutes to talk about the similarities and the differences between this epidemic that we write about and the COVID epidemic. There are many similarities. They're both striking low-skilled, less educated workers harder. They've both been made worse by distrust in government. They both highlight problems with the public health system in the US. And they highlight reasons why tying health insurance to employers is a miserable way to fund the healthcare system. However, there are differences between them. People of color have been hit much harder by COVID than have white non-Hispanics, while the opposite was true for about 25 years in the deaths of despair epidemic. Deaths of despair have been heavily concentrated in midlife, COVID among the elderly, And there are vaccines for COVID, but there's no vaccine available for deaths of despair that took 164,000 lives in 2019, the last year for which we have full data. There's no reason to believe that's going to diminish. And I'm just going to leave you with this last slide, which is from our current work, which looks at COVID mortality rates by race and ethnicity, by age, depending on whether or not we're looking at people with or without a college degree. And one of the things that several profound things I think jumped out. One is the extent to which American Indians and African Americans and Hispanics have been walloped by COVID. Another is the fact, though, that if you look at people with and without a college degree, the ones without a college degree are twice or 3 or 4 times more likely to die than are people with a BA. So on that cheery note, I am going to come back to you, and I'd be delighted to take questions.
Wow. Thanks very much, Anne, for this most compelling and problematic talk. We have some questions already. Let me start with one of my own, which is whether there has been any decline in deaths from opioids since all of the actions that have been taken to try to curb that scourge.
That's a really good question, Bob. It's the case that among prescription opioid overdoses, those have dropped. That they started to turn the taps off of writing prescriptions for these very heavy-duty opioids. Unfortunately, though, heroin is a perfect substitute for OxyContin. So that there was a second wave, a heroin wave, which has been followed now by a fentanyl wave, which is about 100 times stronger than heroin, which is absolutely deadly. And during the COVID, there's been a lot of debate about whether or not COVID would cause the death rates from drug overdoses to go up. But 2 things happened. COVID hit, and at the same time, fentanyl made its way west of the Mississippi River. So that the COVID deaths were rising before lockdowns, before the COVID pandemic took place. And we're parsing out whether or not the increase in drug overdoses taking place right now is due to COVID or due to this fentanyl epidemic that we still don't have our hands around is anybody's guess.
Martha Farnsworth asks whether you see a difference for non-bachelor degree holders who have skilled occupations like the building trades and various kinds of technicians.
That is also a really good question. Unfortunately, while we have education on the death record, we don't have occupation, we don't have income, we don't have wealth. And so we're limited in the ways in which we can use these death records. Now, in the future, there's work that may take place where these death records may be able to, under special circumstances, be linked to censuses, in which case we would be able to look at occupations. But currently, that's not available to us.
Joel Cohen asks why American healthcare is so expensive, and what do you recommend to control its costs and improve its quality?
So we think that any health insurance system has to cover everyone, and it has to have price controls. And in the US, we live with this fiction that the market can provide healthcare, even though going back to Ken Arrow, who's sort of the father of proving all of Adam Smith's theories about the market and how well it works, Ken Arrow said you cannot use the market to provide healthcare. We have not controlled the prices. We've let the AMA, through its cascading down effects, control the number of residencies, restricting the number of doctors, which keeps the wages of doctors high. Hospitals have been allowed to merge and merge and merge. And instead of there being synergies that bring prices down, when these hospitals have merged, prices have gone up. It's also the case that pharma does not have to negotiate with the federal government, who buys a very large number of their drugs, on prices either. So my colleague Uwe Reinhardt, who was just such a fabulous health economist, would say it's the price is stupid. And it's largely because we have been unwilling to control prices for all of the different parts of the system.
Annie Westcott, I think, has a question that was initially posed by Linda Greenhouse.
Linda Greenhouse asks, where is the money being spent on healthcare actually going? My impression is that primary care physicians are making less now relative to in earlier years. Is it going to the hospital industry or where?
That's a good question. We have a total breakdown in the book, but hospitals are a really big part of it. But it also does turn out, I mean, I love my doctor. I love doctors. I think doctors are great caregivers. But there are subsets of doctors who make a very large amount of money. They are the largest single occupation within the top 1%. So doctors are certainly getting their share. But it's also, if you have a hip replaced, the parts that go into the hip replacement, which come out of the same factory, whether you're having the replacement done in France or the US, the parts cost 3 times as much in the US. The drugs cost 3 to 4 to 5 to God knows how many times more in the US. So it's a little bit for everybody, but hospitals are a really big part of the story.
Mike Hout asks as follows. He notes that the U.S. also stands out with respect to gun ownership, and he wonders what share of men's suicides involve guns and whether if it was harder to get a gun, deaths of despair would decline.
Mike Hout, that's a great question. Unfortunately, it's really hard to do research on guns because the NRA got Congress to defund any research that they were funding that collected information on guns and gun ownership in the US. The last time it was collected was in the 2004 Behavioral Risk Factor Surveillance System. We do know that proximity to a means is important when someone commits suicide. It doesn't, I mean, almost anyone could figure out how to strangle themselves. That is true. But having the means there and ready, and given that guns, unlike pills, with a gun, you almost always complete the suicide. That's got to matter. But that said, it's very hard to, if you're looking, using the old data that we've got, county by county, we don't find a correlation between suicides within a county and gun ownership in the county, although those numbers are quite old. But certainly just going by the rule of thumb that getting rid of something that's proximate that one could use, that is almost 100% always deadly, would probably help.
Going back to the cost issue, Howard Block asks about the role of insurance companies and the excessive cost of medical care in the U.S.
Yeah, I mean, we spend an enormous amount on the health insurance industry. There are a lot of jobs there, right? So one person's excess is another person's paycheck. But we would argue that these talented people who, when you call on the phone and say, I don't have a first clue how to read this bill, are able to tell you why you're being charged, what you're being charged. Those very talented people could be doing something much more productive in society than explaining to you why you're being charged exactly what you're being charged. So we think with time, with the transition, we might be able to make that industry smaller.
I'm going to ask one last question from Linda Kerber, and then unfortunately, although we have a great many questions, we are going to have to move on to the next presentation. But Linda asks, in the years since you first started warning about deaths of despair, have you seen any arguments for increased accessibility of college education that have been effective in skeptical legislatures?
I have not. We do believe that anyone who wants to and is able to go to college should, but we also think that we need to, as if healthcare industry wasn't having enough lift, we think we need real reform in the education system so that people who are not college bound leave education with a skill set that will get them a good job, a job with a living wage. And so we should be looking toward Germany. We should be looking toward apprenticeship systems that could also be useful.
Okay, well, thank you so much. I'm sorry we couldn't ask all of the questions here. We will collect those and pass them on.
Please do.
To Anne. And now we have to move on.